Hello, everyone. Welcome to our webinar, The Concentric Value of Vaccination, Understanding and Restoring Vaccine Confidence. This is the fourth in our CVV, Concentric Value of Vaccination webinar series, and appreciate all of you joining and hope that some of you are repeat attendees. My name is Ilana Kiefer-Blass, and I am the Director of Strategic Alliances here at the Gerontological Society of America. Next slide. So this wouldn't be a webinar if we didn't have housekeeping items. So this webinar will be recorded and it will be available by the end of today or tomorrow on our learning management system, GSA Enrich. We will also share it with all of you. We at GSA, we want to share our information far and wide. So hope that you will send it to your friends and colleagues as well. We will, of course, have a Q&A session at the end of today's webinar. So we ask that you put your questions throughout the session in the Q&A box. We'll only be able to see them in the Q&A box. There is a short evaluation at the end. So we ask that you just stay on for a few seconds to fill that out as well, because that will help inform future webinars for us. Next slide, please. So as I mentioned, I'm Ilana. I work at GSA. I focus on the topic of vaccines, as well as on the growing, emerging field of age tech and opioid safety and financial security, among other topics. And our featured speaker today is Dr. Angela Shen, who is an adjunct associate professor in the School of Medicine and senior fellow at the Center for Public Health and at the Leonard Davis Institute of Health Economics at the University of Pennsylvania. Dr. Shen is a vaccine policy expert, as you will clearly see during today's session, as well as a health services researcher with over 25 years of experience, specializing at the intersection of policy, practice, and research in health disparities, access to immunization services, vaccine confidence, today's topic, and barriers to innovation and global health. And she is a retired captain in the U.S. Public Health Service. So before we turn to Dr. Shen, I just want to share a few other things. Next slide, please. So this month, August, is actually National Immunization Awareness Month, otherwise known as NIAM. And for those of you that are active in the vaccine space, you've probably seen a lot of different social media posts and articles related to this topic and to this month, including from GSA. So we just want to wish everyone that happy month. And of course, we want to make sure that you are aware of our vaccine work, which you can go to right here with the QR code and the easy to use URL, where we have a full report called The Concentric Value of Vaccination, Intersecting Health, Economic, and Societal Benefits, as well as a one-pager that succinctly distills what is in that report. And that in particular is helpful, and we hope that that will be shared in an easy way to explain the many different benefits of vaccines. Next slide, please. So I also just want to give a plug. So GSA, we have our annual scientific meeting coming up on November 4th through the 7th, and that's going to be in National Harbor in Maryland. Anyone on this webinar that has already registered for the conference, thank you for that. We will have a momentum discussion on this topic, on the topic of vaccines. It's called The Concentric Value of Vaccination, Education and Communication about Immunizations for Older Adults. So momentum discussions are kind of large-scale panel sessions that have a dedicated time where there are no competing scientific sessions or workshops. And you can actually, even if you've already registered, you can follow these instructions, which we will of course send out with these slides, to register for this specific momentum discussion. And if you haven't yet registered, this is a great opportunity to remind you to register for our annual scientific meeting, as well as for our momentum discussion on this topic. Next slide. So we have been doing this CVV webinar series since the beginning of the calendar year, and I just want to do a very brief recap. Our first webinar, which you'll see on the left-hand side, was an overview of how vaccines actually work in the body to protect us from specific illnesses. And then we also highlighted some research that was recently published in one of our GSA journals that show that there's actually an association between the shingles vaccine and the slowing of biological aging. Just getting the vaccine can actually is showing signs of that. So we encourage you to check out that webinar. Our second one was on the economic benefits of vaccines in general, and we did a deep dive into the economic benefits of the flu vaccine. The Global Healthy Living Foundation had recently released a report that showed that the flu vaccine, I'm sorry, that influenza in the flu season of 2023 and 2024 actually cost this country $29 billion with a B. And of course, if more people had received the flu vaccine, we could reduce those costs pretty dramatically. And then in the third webinar, again, we were going to health, economic, and societal benefits. In the third webinar, we were focusing on the societal piece of it, and we focused on the topic of resilience as relates to immunization in older adults. And it featured former GSA president, Dr. Barbara Resnick, who was a nursing professor at the University of Maryland. And I encourage you to check out all of those webinars, which are all available on GSA Enrich. Next slide. So very briefly, this is our framework for CVV. We talk about the health benefits, which are more well known among the population. Getting vaccines help you prevent disease or mitigate symptoms, increase life expectancy, keep you out of the hospital, etc. Next slide. There are also economic benefits like the flu report that I mentioned that people don't always realize that actually having access to vaccines and taking them really can reduce costs for individuals, for families, communities, and society at whole, as well as ensuring that people are able to continue going to work and caring for their loved ones. There is one study that showed that adult vaccination programs yield a return on investment 19 times, the original investment through reduced illness, fewer hospitalizations, as well as greater labor force stability. Next slide. And then, of course, there are also many societal benefits to immunizations. So as one example, it promotes health equity because not everybody is able to receive vaccines for a variety of reasons, but the more people that have them, the safer and healthier we keep society as a whole. So with that, I'm going to turn to our featured speaker, Dr. Shen, to talk about vaccine confidence in older adults, addressing the elephant in the room. Take it away, Dr. Shen.
Great, thanks so much. Next slide. So vaccines are available now across the life course. In the olden days, which is not very long ago, my kids always talk about, when you were young, did you guys have electricity, things like that. And so wherever you anchor olden days, a lot of people have often associated vaccines with wee itty bitty babies. But now we have a pediatric schedule that includes an adolescent schedule. We have a schedule for adults as well as older adults. This is my family, so I have permissions to use these photos. My daughter here getting her COVID shot, myself in front of a famous statue in front of the World Health Organization, and my father probably the last season that he skied. And so we're very fortunate that innovation has brought us these benefits to be able to vaccinate and protect our family across the life course. So what are we going to talk about today? So in the next 45 minutes, we're going to talk about the vaccine enterprise as a whole. What is hesitancy? Sometimes you hear the phrase vaccine confidence, why it matters that we frame it differently. What does hesitancy look like in older adults and in long-term care? Does it look the same as it does with children and with adolescents? And determinants of decision-making, feature a few studies that I was part of, and some strategies and takeaways. Next slide. This is a slide that I used to have animated, and people either love this slide or they hate this slide. I love this slide, which is why it's here. And the reason I love this slide is for three reasons. There's a lot of boxes here, and the boxes show that there are a lot of different component parts to the system. There's a dotted line, and on the left side of the line in general is the vaccine enterprise, all the bits and pieces that are required to bring a vaccine up through licensure. And then to the right side of the dotted line is largely what one might characterize as the immunization delivery system, the bits and pieces that many of you as healthcare providers, researchers, what have you, in terms of getting the vaccine into the arms or the noses of patients. The reason I like this slide is one, like I said, it's got a lot of boxes. Two, it shows that these boxes are interconnected and they impact each other. And three, it gives you an overview of the left side, the vaccine enterprise, and the right side, the immunization delivery system. And so I start with the arrow in general. It starts along the left side and works right. So we're not going to go through all these boxes, don't worry. And so it starts with a recognition of a public health priority. And the left side is a lot of the laboratory things in which people do research, surveillance to characterize that there is a scientific feasible way to make a vaccine against that public health priority, against a disease that is potentially vaccine preventable. And then on the right side, we kind of end with our outcome or what we're gunning for, which ultimately is to reduce morbidity and mortality through population health. And that arrow is pinned on high vaccination rates. So that's somewhat kind of the eye of the prize. What we're going to talk about today is the two circles in the middle, elements around communicating and educating and education strategies to get to our goal, which is influence and influences attitudes about vaccination and vaccine acceptance. And so we publish this. The link is on the bottom right. You don't have to love it. I love it, which is why it's on the slide for those things. But I do recognize it's very, very busy. And there's a lot of arrows, particularly in the summertime, to try to follow. Next slide. And so what you need to know kind of in general, when I was at the FDA, the Food and Drug Administration, we had to take this one class called how to write in plain language. And it was super duper helpful because as scientists, clinicians, researchers, we give a lot of background in science. Think about the construct of a paper. You have the background, methods, results, conclusions, and you kind of takeaway gets buried at the end. And so I thought about this class, which I took 20 some odd years ago, and they're right. And in this class, as we did a lot of the background, communication is really important to kind of nail your message through. And so what I found that I ended up doing is I would write all the background, all the things that my boss or whoever I was communicating needed to know. And the takeaway was at the bottom, and I cut and pasted that bottom and put it on the top of the note of the email. And so I started trying to do this with the slides as well, in case you have to knock off, go to the bathroom, pick up children, or just lose a connection, that this is kind of the takeaway in general, and we'll go into the deets afterwards. So in general, the takeaway is there's a lack of confidence in vaccines, and it poses a threat to public health. Vaccination has been super duper successful, but there's a lot of variation by region and within a region, within communities. There's disparities that exist. And what this translates to is that there's pockets of under vaccinated, which means there will be and can be outbreaks of disease. There's a lot of common concerns that people have, largely around safety, so unknown future effects, often with new vaccines, side effects, which are related and linked to lack of trust, and we'll talk a little bit more about trust in a few slides later, and the perceived risk perception of that disease. You know, am I vulnerable to that? I'm really healthy, or I have protein shakes in the morning, or I'm young. I added this line, this bullet, because in recent years of late, there's been an increased resistance in vaccines, a lot more skepticism. COVID polarized amongst a number of activities around the COVID campaigns, polarized our nation. And for a very long time, hundreds of years since there was the first vaccines have been controversial, but they've never been politicized in the way that we've seen today. And so there's still very much generalized bipartisan support, which is not the crux of this but there's a lot of op-eds I've written myself. And so that's kind of a common concern amongst us in public health and you with your varied backgrounds of who is listening on the webinar as well. The next takeaway is that there's no single intervention. There's no single intervention that's likely to address vaccine hesitancy. So there's not like one-stop shopping. Something that will work in engaging with one patient may not with others. There's also local approaches that are really critical to meeting the needs of the population and the community in a tailored way. And specifically recognizing that this webinar is to GSA, pardon me, it's still summer brain, is that long-term care has two distinct populations, both the residents that live there as well as the workers who care for them. And I specifically say workers because they're not just the providers, but many others that take care, including food service, front desk, so on and so forth. Next slide. And so let's look a little bit of definitions and level setting. Next slide. And so what is hesitancy? You hear that a lot, and what it is, it's a delay in acceptance or it's just a flat out refusal of vaccine, despite the fact that vaccines are available. It's really complicated. It's often context specific, and it varies across time and place and vary by the vaccine. So some people may be like, I'm good with this vaccine, but I'm not so good with this one. Go ahead, bring on, give me a Tdap shot, but I don't really want a hepatitis B shot. And so it's not a monolith in which you're either hesitant or not. Folks have different views, attitudes, and feelings, of the vaccine. It's influenced by complacency, convenience, confidence, socio-demographic factors, structural factors such as health inequalities, SES disadvantages, and systemic racism. On the right-hand side in the blue box, you'll see a definition of confidence. Confidence is the trust that parents, so myself as a parent, as well as myself as a patient, I suppose, providers have in the vaccines themselves, in those who administer them, and in the upstream and downstream systems, so the lots of small boxes we talked about, that's responsible for the development of the vaccine, the licensure or authorization in the context of COVID, and the manufacturing and recommendations for use. In order to build vaccine confidence, which is the way that we frame it, identifying that people are hesitant. Next slide. That we need to build trust that parents, patients, and providers have in those three things that are the points of the triangle. It's about how folks perceive vaccines and the recommendations. And so vaccines I put on the top of the triangle. You could probably tell my kid just took geometry when I made these slides. Those who administer them, healthcare professionals, and the system, which we talked about the system with lots of small boxes. What we haven't talked about, which is super duper important, is letter B, that healthcare providers are trusted sources of information. They're extremely influential in shaping uptake. You as a provider or your own provider is the single most important determinant to whether or not someone gets vaccinated or not. Having said that, when a provider communicates effectively about vaccines, the benefits, the risks, as well as the value and the need, including talking about vaccine safety, people are more confident about their decision. To do this well, healthcare providers need to be confident themselves about the safety, effectiveness, and efficacy and importance of vaccination. Next slide. And so just like we talked about, hesitancy is specific to each vaccine. Hesitancy is also a continuum. And so understanding how vulnerable communities wish to receive messages, from whom these messages should come from, and what those are is pretty critical to tailoring strategies to address individuals in the movable middle. And I show this in a couple different ways. So I start with this one. My daughter says it looks like a Hershey Kiss, which is really good because some people have told me it kind of looks like poop. And so we'll go with the Hershey Kiss. So at the bottom of the Hershey Kiss, you have unquestioning acceptors. No questions, concerns, bring it on, we're going to get vaccinated. And in the very top, you have vaccine deniers. No way, Jose, never I'm leaving. And so this continuum is also important. It's summer brain. It's also important to recognize in this continuum that the area of the Hershey Kiss, if you will, is reflective of the proportion of the population, which means in regular plain language, there are more people on the bottom of the Hershey Kiss than the top. But the top people, the vaccine deniers, are the ones you hear a lot about in the news. And so unquestioning acceptors means no questions or concerns. Cautious acceptors, I have some concerns, but I'm still going to get the full schedule. I'm hesitant. I have a lot of questions. And can you please help me answer those questions? Late or selective. I think I'll get this one now. I'm going to think about the other ones. And vaccine refusers is like, no, no, thank you. And vaccine deniers. So you see this continuum from the bottom to the top of the Hershey kiss. Next slide. And so this is a different way of looking at it. And so if we go back to the last slide, sorry, I have one more thing to say. When we talk about the movable middle, we talk about messages targeting not at the bottom of the Hershey kiss and not at the top of the pyramid or the Hershey kiss. We talk about the movable middle because people on the both ends of the spectrum, next slide. Sorry, on the next slide, you are most likely not going to change their mind. So this is a different way and a different framework to look at something similar, which my point is you have the immunization advocates or the unquestioning acceptor on the right, and those on the left, which are no way Jose, and those in the middle, framed in these different ways by these two great researchers. So a fence sitter, I'm not really sure. Go along to get along. Okay, I'll get vaccinated. I have to get vaccinated. Everyone else is getting vaccinated. I need to get vaccinated to go to my job or for my children to go to school. Health advocate. It's really important to be healthy. And so these percentages that are reflective of the Hershey kiss in the slide below, meaning that you hear a lot about hesitancy, you hear a lot about people's concern, but much of the population gets vaccinated either partially with the schedule or full. A different way of looking at these characteristic archetypes are in the bottom as well. Refuser, late selective vaccinator, the hesitant, cautious acceptor. I think you guys get the gist. All this is to say two takeaways that there's a spectrum of acceptance. And the second is we're targeting the folks in the middle, which we call the movable middle. Next slide. We have a lot of evidence on how to overcome fears about safety or different elements of vaccines. And this is an example of one using a recent experience that we've all had, which is living through COVID. So with the willing majority, you have different strategies than the reluctant minority groups or the movable middle. And you can see those strategies here, which you can read the slide yourself, in which for the willing majority, you make vaccination a default. You send reminders, don't forget to get your second shot because, there's a 2-shot series or a 3-shot. There's an intent to act. In the middle, you empathize first and don't necessarily correct, but you personalize it or make vaccinating a norm. But there's a lot of questions to be had for which providers, the community tries to answer those questions. And the reluctant minority reduce barriers to make vaccination more accessible. Sometimes access, which is a very loaded word because it means something different to some people than others, may mean insurance coverage. It may mean I don't have a car to get to my doctor or the hours aren't accessible. There's different ways that we have found work to get those people in those groups vaccinated, like partnering with community leaders or acknowledging distrust and be upfront about what's known and what's not. Consider messages and constructing messages that resonate with core values. Next slide. We learned a lot in COVID. We learned a lot about building trust, and the efforts are really critical to helping certain communities, particularly minority communities, in engaging about vaccines. We also learned that the best messengers for this content are often those that are close to home, those influencers within their community. In particular, as I touched on earlier, your personal physician is one of the most influential people in this decision process. In a study that I did during COVID, one of our study participants said to me that to our research team that her children go to the same pediatrician that she went to. People have a lot of trust in their pediatrician or their provider, and so they have a lot of influence. That example is around pediatrics. I had another person tell me that their father really trusts their cardiologist and listens to their his father's cardiologist more so than he does his primary care physician. This individual is African American. His cardiologist is African American. He connects with him, and his cardiologist resonates with him more than his primary care physician. And so his cardiologist has a lot of influence. You hear a lot in I don't know everyone's background, but there's a lot of educational materials, trainers, effort, FAQ sheets invested in educating the healthcare providers because of this point that the healthcare providers have a lot of influence on their patients. We know this is a courtesy of a colleague at the health department. A lot of respondents in this study don't really know really very much about how vaccines work and or how they're made. And people know a lot more now post-COVID than they did before because of what COVID highlighted in terms of all the little boxes that I showed you early on, and the need for all those little boxes to work together to get a vaccine license, and then all those little boxes to work together on the right side of the dotted line to get someone vaccinated. A mentor of mine, a retired admiral, said, Angela, and he says this to everyone, and you've probably heard this in other webinars, a vaccine is 0% effective in the vial. It's 100% effective when you use it, but it's 0% effective in the vial. I kind of messed up his quote, but I think you get the gist. Next slide. And so building trust and social norms, really some of these links you can touch on kind of tap into what we learned in COVID and the previous slide. Next slide. So hesitancy in adults, one of the studies that I did surveyed and talked to parent decision makers as a decision maker for their children, which looked a little bit different than a decision maker for yourself as an adult. And so in this slide, we talk about hesitancy in adults as opposed to hesitancy in parents in terms of making the decision to vaccinate their child, but there's a lot of overlap. And so given that this is GSA, we're going to talk about this slide. And there's a combination of reasons. So people, are concerned about safety and side effects. Boy, that vaccine was really developed really fast. Is it safe? Some people have complacency. My risk is really low. I'm a senior. I don't go out much. A lot of this I've heard from my parents as well. I've had to convince my parents or talk at length to my mom. And at the end, I said, Mom, do you know what I do for a living? I mean, the answer was no, but there was an irony there. She's like, I don't really need this vaccine. I'm like, yes, you do. And these are the reasons why. There's misinformation and mistrust. Some people have a lack of trust of the healthcare system. They had a bad experience and they don't want to go back again. You see in the red quotes, I hear a lot from my friends and the internet about rumors. It says it's on Facebook, and if it's on Facebook, it's got to be real. And so I don't really know if I want to get vaccinated. We were on holiday in Spain, and we were in a cooking class, and the woman next to me as a 2-year-old, they just got married, and order of operations and the way they did it. And, and they were not sure whether or not they're going to vaccinate their child. And not because they're hesitant, but because there was just a lot of things cooking on Facebook and otherwise. And I said, you should get your child vaccinated. And she turned to her husband and said, honey, this lady works in vaccines. She said we should get him vaccinated. And they both said, okay. And so it was really impacted me that the influence of what, people saw on Facebook, it made them question something that they had never really intended on questioning in the past, or they didn't question with their other children or their other child. And so because there was so much uptick in buzz in their feeds, they're like, well, wait a minute. Lack of recommendation. Well, my doctors didn't mention it, so I'm not going to get it. I trust my doctor, and if my doctor didn't say it, then I don't think, it can't be that important. And logistical and physical barriers. It costs a lot. I don't know if my insurance covers it. I have to go really far. This kind of sounds like my kids, I don't really like needles. And so there's a lot of things that people say, the zoster shot's going to knock me out for a couple days, and I don't have 3 days to spare. I'm really busy. I have a lot of kids. I'm really busy at work. And so hesitancy in adults, we know, looks something like this. Next slide. Hesitancy in nursing homes and long-term care really deserves its own slide because it's historically and obviously currently has two distinct populations. You are contending with the residents who live there as well as the staff who care for them. There are also systematic and institutional barriers. There's a lot of structural friction that limits vaccination that's really unique to this population. There's a lack of in-house tracking, so electronic monitoring of both the staffs and the residents. Storage and delivery constraints, you have to rely on or typically on external pharmacies. And financing and reimbursement is a little complicated. And so it requires absorption models in which you absorb the upfront costs. When I give a lecture at Hopkins every year on this, what's different about vaccines than other drugs that you get, like an antibiotic? And since this isn't engaged, I'll just pretend you guys all raise your hands. And so, if you need an antibiotic or if you need a different medicine, the doctor gives you a piece of paper, a prescription, and you take that to the pharmacy and you get that filled. But in a vaccine, the doctor or the physician, the office has to upfront the inventory. Early on in the around the cusp of HPV and a series of licensures in the 2000s, we had doctors who would like have a power outage and lose an entire fridge of HPV vaccines, and that's $250,000. Doctors don't go to medical school to be business people and run their practices. And that's a whole other lecture on financing. All this is to say is that it can be complicated because there's other stuff, i.e. those little boxes, that are necessary to stand up the immunization delivery system, the vaccine enterprise, if you will. And also in this population here, there's high employee turnover. And so targeting educational efforts on a constantly shifting workforce is a lot of effort. Next slide. Residents' medical and cognitive barriers also complicate things in this population, and I'll leave you these touch points here. Frailty interactions, cognitive decline, burdensome proxy consent, isolation, and complacency. These aren't restricted only mutually exclusive to long-term care and residents, but you could see this population in older adults, confounds things much differently than in other populations like pediatrics and adolescents. Next slide. Staff are hesitant for different reasons and often higher hesitancy than a hospital-based staff. There's distrust of management and authorities, demographic and educational gaps. There's misinformation that's pervasive across the board in different sectors. And there's workplace burnout, which you can imagine leads to pervasive understaffing due to low wages and feeling unsupportive. And so at face value, it may one may not think of all the different domains summer brain and elements that contribute to why people are hesitant. It's not only nor always just isolated to I'm worried about it being safe or not, or necessarily like I don't like to be told what to do. Next slide. We can only talk about so much in 45 minutes if you're interested. These are a couple of great policy solutions. And the nice thing about these papers is that these papers and these organizations invited all those really smart people from all the relevant organizations, and you can see an amalgamation of those. So it's not necessarily just a viewpoint of one particular organization. The highlights from the provider perspective, I was told many of you are providers, I think are very interesting here and quite relevant because there are actual solutions to the barriers that we talked about before. It's not just like this is a problem, we don't know what to do about it. But there's ways such as improving the intake process of patients that come in, integrating efforts into SOPs, and ensuring all employees, including food service, housekeeping, not just clinical staff, are engaged in education and awareness, and improving patient handoff. As adults see lots of different doctors and move across the continuum, not only in different insurances, but across different places that they have care. That's why working in adults is a little trickier. I'm not going to say harder, but harder is probably relevant than pediatrics. I switched my kids to adolescent med, when they were 12 years old. But you get the general gist that, we have, as an adult, lots of different doctors we see for lots of different reasons, and we have other stuff cooking. I went from taking, no medication to like 5 different pills now, for blood pressure, for cholesterol, menopause, all these other things. So we have a lot of things cooking in the kitchen. There are also other perspectives like manufacturers and the federal government and advocacy. I just plucked out a few here from a provider perspective. Next slide. And so I listed when I gave a talk to 100 some odd FQHCs, I asked them whether or not, these drivers resonate in the space that they work in. And you could see these that we've touched on before around unknown side effects, concerns about other populations that need the vaccine more, practical concerns, structural barriers like convenience. For those of you who remember working in 2009 with H1N1, a previous pandemic. At that time, the government, I was with the federal government, we worked really hard to partner with pharmacies, CVS, Rite Aid, and it's hard to believe that if you ask a young person now who didn't remember in the day or was 5 years old, to imagine that you couldn't get vaccines or healthcare services, at a pharmacy, which is very commonplace now. But that was one of the really significant things that happened or came out of the 2009 response is the partnership with pharmacies. And in part because adults really value convenience. And, pharmacies are open later, you don't need an appointment. And so it helps to eliminate every factor that you can that stands as a barrier to getting vaccinated. And pharmacies have a really important role in partnering to improve access to services for adults, particularly vaccines. Next slide. So there are some determinants of decision making, which we front loaded because I kind of spent a little more time earlier, but you can actually see the papers, which this is an adapted matrix from the World Health Organization's hesitancy group. So there's a lot of individual factors, what people feel and think, their own attitudes and their knowledge base, group factors, their trust with their providers, their experience with their health insurance or their health system, vaccine-specific factors we talked about earlier, how much data there is, what the trials look like for that particular vaccine, and contextual factors in terms of, we talked about social media, historical influences, how they were, what their parents had told them, how their family feels about things, the culture. One of these things reminds me of kind of Thanksgiving, on what you talk about at Thanksgiving and what you don't. And all those bits and pieces kind of feed the arrow down into motivation. My intent to vaccinate. What am I hesitant about? Or am I willing? What do I accept or not accept? And that leads to a potential outcome, which could be refuse, but that refuse could change to a delay, and that delay could change to vaccinate. Next slide. This is another, NONI has also the similar working group and it's adapted. You can look at it a different way. So this model is called the 3 Cs, but you see that those components are in there that we talked about. And I talked about these 3 Cs earlier, but really quickly. So confidence is the most difficult one. It's the one that it focuses on trust, which is why we had so many slides that talked about trust, as well as getting information that's reliable that you trust. Convenience, we talked about bro. I have kids who say bro all the time. So if you have to take 3 buses, get off of work, what can we do to remove barriers? I get text messages all the time to remind me about library books and this, and that's really helpful. And it's in this middle bucket. Complacency touches on the recommendation to you as a provider or what your provider, and it raises awareness about disease. We are in a time where a lot of colleagues are making jokes about how, the increased rise in these diseases are, helping train doctors who never would have seen manifestations of these vaccines, would never have seen a measles case. I have a slide that's a little bit too much for this webinar, but it shows the manifestations of these vaccine preventable diseases. And I have stories associated with that as well, but we have to keep to time. And you see how these 3 Cs kind of overlap, and they're factors that contribute to hesitancy, the confidence piece, the complacency and the convenience, and you can see the practicalities of that around how much it costs or the schedule, your health beliefs, your social norms, or whether or not you perceive you're at risk. I started having protein shakes every morning because my doctor wants me to have more protein. So I'm invincible and I'm healthy and I don't need to get vaccinated. Media, history, politics, all those things kind of get roll together and influence people's decision on whether or not to vaccinate, think about vaccinating or not. Next slide. We did a study during COVID and we took a look at trust. And specifically, we wanted to see and talk to community-based organizations about messages. And you probably saw in COVID that a lot of CBOs were used to deliver important public health messages. Why? Next slide. Because it's not just about on the bottom left what is being delivered. It's about who delivers that message. And so when we went and we engaged with and then how that message is delivered, whether or not it's electronic, whether or not it's in a flyer, whether the mode. And we went and we talked to a handful of community-based organizations in Philadelphia, and people trust their CBOs that have been in their neighborhood for 50 years, for 80 years, for 100 years. And so by having access to those CBOs, if the CBO vouches for you, working with a trusted spokesperson to reach out, then that their kind of trust transfer you. If they're cool with you, then I'll listen to you. The CBOs, empathize with their community. They understand their points of view. It's a very safe space to come to their local church or to come to a food bank that's been there for 50 years. And it helps people with agency to make a plan to vaccinate or not, to get reliable information and to be able to communicate and increase access to the community from these trusted sources. And so because of this, what we characterize as a trust and influence loop, you saw a lot of public health departments and agencies across the country partnering with community-based organizations. Next slide. And so we learned that, these credible sources, these well-established entities, in addition to your primary care provider, are really important to provide them with top sources of reliable information. We learned that being neutral, being honest, talking about what you know and what you don't know, and relying on, as opposed to relying on people to sift through volumes of information, which sometimes conflict with each other, is really highly valuable. And so we learned that what may seem obvious now is that trustworthy qualities are that they're experts, they're fact-based, they're unbiased, they have an established process for sharing information. And because of the information that we became aware of in COVID was always evolving, it was very tricky to kind of wrap your brain around what's right, what's not, what do we know now, different than what we knew yesterday. Next slide. We came up with a framework called Aspire. You could click the QR code here and you can see, assume people want to get vaccinated, share key facts, present a strong recommendation, initiate a discussion, particularly about side effects, and respond to questions, actively listen and empathize. Next slide. And so we talked a lot about this in earlier slides, that vaccine messengers are really the ones that can learn how to build trust. And in this particular study, we did that with existing CBOs. Creating a safe space to have that conversation is a really important inflection point that we're at now, as folks have a lot of questions that have been prompted by the escalation and the politicization of vaccines. Vaccines are always in the news for one thing or another. Next slide. We talked about this being clear, detail-oriented, and trust. Next slide. I also thought sometimes people talk about CDC sources, sometimes they don't, because there's a decline in trust in CDC. As a former CDCer, I can't really give a talk without putting at least one slide in, which is generally as you look at this slide, know the elements of effective conversations, starting from a place of empathy and understanding, assuming patients will want to be vaccinated, but prepare for questions, give a strong recommendation. And some examples, some of the work that I've done has been working with groups on how to talk about things, because people may understand this conceptual bullet points of what we're talking about, but they not know how to say it. this shot is especially important for you because of your job or underlying condition. And so we've learned or seen, or I've seen that, in some spaces that there's a need for what that script looks like. Next slide. This evidence-based strategies, we know these things work to be localized, to talk about improving access, community engagement. We saw this increasingly more during COVID. I work with low and middle income countries in global immunizations, and then this is the main staple of how a lot of vaccinations and health services are delivered, very localized with community engagement of trusted extension workers, healthcare workers. And so we saw a lot more of that in the United States during COVID. Train those who are involved. Effective interventions include educational campaigns or making things easy, which we talked about, like on-site vaccination. Every year when I was working at HHS, I'd go down to the second floor and see Nurse Jane, for my flu shot. And it's really nice to have that at work. There's other policy interventions. There's a lot to talk about. There's a bunch of policy interventions like improving insurance coverage or data sharing and things that go back to, maybe you can see why I like that slide, the earlier one with all the little boxes. And so all those little boxes, amongst those boxes, there are some policy interventions that, if ironed out, can also kind of pave an easier glide path. Next slide. So we talked a lot about communication and communication with families, be aware of cultural and emotional differences, unique contexts, checking for understanding, adjusting for styles based on like literacy or education or language, avoid using jargon or stigmatizing language. I have so many stories. I need to stop telling stories. And then I put a link here because I thought this WHO Euro puts out a lot of really good things around communications. This one was specifically like responding to vaccine deniers in public. If you're at a town hall or and then so there's a reference for you there. Next slide. Here are some resources as well. On the top one, it's CDC resources as well as the NVAC adult standards. The PALTC is the organization around, don't ask me what it stands for. It's the long-term care. And so they have a CDC funded project called Moving Needles. There are 3 online modules there that are open to anybody. My team, as a consultant, helped design these. And the 3 here are around immunization essentials, kind of immunizations 101, in particular in RSV because they're newer vaccines. And because 80% of the vaccine pipeline is targeting adults, then PALTC asked us to also do a module on that as well. And so they don't cost anything, and you can access those through a CDC funded project called Moving Needles. Next slide. As part of this project as well, there is a frontline a staff survey. There's some templates. There are some educational materials like fact sheets and videos, as well as kind of a guide to help facility raise rates. Recognizing this is particular for long-term care, some of these bits and pieces can be used in different domains as well. Next slide. So let's see what I wrote as the takeaway. So the takeaway is healthcare providers are a trusted source. I think I must have said trust about 80 times because they are. They can influence local vaccination rates in individuals, which translates into the population. Barriers for one community may be different for other communities, and that is also relevant for motivation as well. There are a mix of issues at play when it comes to hesitancy, and on the flip side, building confidence around communication, education, and access, and that requires deep engagement. There's a different conceptual model or construct called the 5 A's versus the 3 C's around this Thompson paper around access, so reaching vaccination, affordability, awareness, knowledge of, acceptance, activation. There's a lot of research around kind of nudging. And the digital divide is a barrier. particularly for some older adults, but not all. There's plenty of people who are much more adept digitally, particularly than I am. But I know that every time I see my mom, who's in her 80s, it's pretty much a prerequisite that we have to do some sort of lesson on her iPhone or iPad, and she gets super excited. She also slaps my hand because she wants to practice on how to move the icons and things like that. And so personal experiences can also be influential. We know that a lot of people, when they are exploring something, they may look on the internet, they may talk to their provider, but they may also ask you, hey, you are in vaccines, or you work in a hospital, or you do research in older adults, or you work for GSA. And so what we learned in one study, or actually a number of studies that we did, is that people collect different pieces of information from different sources and then process that to kind of spit out their output on whether or not they're going to get vaccinated, whether or not they intend to, they just haven't gotten there yet, whether or not they're thinking about it, the different buckets around the continuum. And so your personal experiences can be influential. I'm going to a quick time check. I'm going to a wedding in 2 weeks for my niece, and evidently Aunt Mary's not going to be there because she had shingles. And so, the whole family of age eligible made sure that everyone got their shingle shot because they see and they're seeing, how devastating it is, for Mary to go through this. I've heard patients say things like this, having shingles is worse than chemotherapy. I had another patient say that, they'd rather die. It's really painful. And so personal experiences, not in a scare tactic, but in personal experiences, well, maybe so, can be influential. And I think it was in this paper, there was also a 6A, which you can add. It's also handy. It starts with an A. Accountability in terms of working together to bring vaccine to the community or collectively to foster a social norm for vaccination. Next slide. We know historically that we've worked in an information deficit model. I can't tell you the number of pediatricians and docs I've talked to. Well, if you just give them the facts and they'll vaccinate, they just didn't know. And so for the years, the paradigm was simply giving the right information will turn people to vaccinate because they just didn't know this. And this approach has not worked to address people's needs. Healthcare personnel also need to explore new ways to build confidence as hesitancy is on the rise, and it was certainly amplified by the pandemic. Next. So it's not just about the facts. Attitudes lead to trust. Caring relationships are important with healthcare personnel, patients, and parents. And there are deeply rooted reasons why people may not vaccinate. There's a broader social context. There's a psychology around changing behavior. And I have lots of stories around, weight loss or otherwise. And it's not so much in older adults, but broadly. And so in another module that I did for a children's hospital, acceptance and the circles are important because many people accept or wait and get more information, or I'm worried, or don't consider vaccine to be a benefit. Next slide. Take a guiding style, work with patients, families to build trust, explore doubts, take time. Don't take a traditional directive, argumentative, you do this, I'm the doctor, you're the patient. I went to medical school. Did you go to medical school? Don't identify and solve the problem necessarily or argue and debate with the client, and don't rush through without listening. Next slide. Thanks for the kind invitation to speak. I'm so sorry that I can't see your smiling faces, and I hope this was helpful and that I don't know if you have to enjoy the talk, but hopefully it was good. Thank you so much.
Well, I have a smiling face because I just want to thank you so much for this very comprehensive overview. And I'm really glad that we will be sharing these slides because there's so much rich information on all of them. So everyone can rest assured that we will be sharing those slides. So thank you, thank you. We have actually a particularly good question for you from one of the audience members, which is that he pointed out that low vaccine rates and low confidence in general is not just a public health issue, but it really undermines economic growth and national security, which fits well with what we talk about in terms of our CVV framework. So can you comment on kind of using those messages, especially with audiences outside of the traditional public health audience, such as the Chamber of Commerce and others?
You mean who to use the messages for, or I wrote
Kind of
down low
who
economic.
to and which messages might resonate with different types of non-traditional audiences that are not explicitly focused on health and public health.
Okay, so I'll give you an example. So there's different ways to kind of frame what this is. And so when I moved to the town that I live in now in Pennsylvania, for some reason I asked the nurse, you know, I don't know why I asked her, but I asked her how many kids have exempted or opted out of vaccines. And there was a fair amount. I don't remember the exact number, but just say something like, 12 or whatever, right? I'm like, okay. And I was talking to the nurse and she said, as soon as she explained to the parents, to the moms, that if there's a case of X vaccine, if there's a case in a suspected case in the classroom, their child was going to be out for 3 weeks. And so I
Hmm.
said that after you told them that, how many of those families remained unvaccinated? And all of them. So it was zero. And so the argument that the nurse put forth was really around um, their, however you want to characterize it, their value for time. And so if
Yeah.
you don't vaccinate, it's your choice to vaccinate, but know the consequence of that, which is time. So we've heard a little bit about that in terms of economic impact. We've learned about that in a lot of the econometric pieces that you've seen in the CVV study or paper that you've done, because of the way that we calculate not just direct benefit or loss, but also societal as well in terms of dollies and qualies and days lost and things like that. We also, I've noticed, I was thinking about writing an op-ed on this. There also noticed that there are different messages that folks are framing, not directly around the benefit of lives saved, mortality, herd immunity, things like that, but around different triggers like, days lost. Like you need to take off X number of days of work,
Yeah.
if your child is sick. And so that's just one example of a message that resonated kind of in real life when I moved out
Hmm.
of DC into this town that I live in, and it dropped down to zero.
Wow.
So the
Um,
public health message is still inherently there. It's
it's
just
kind of
framed
baked
in a,
in,
it's
right?
framed in a different way, of which it's centered around, okay, it's your choice, but know that your kid's going to be out for 3 weeks.
Yeah. Yeah. And I think that that choice piece is important in terms of messaging, but we want people to make the choice still to get vaccinated.
And I think you're getting, I know there's not enough time on whole people, but the other thing is around values. I only had half a bullet point on that. And so a lot of the, how you say, friction now is around personal liberties. I just submitted a
Yeah.
paper where we looked at mandates and exemption laws in all 50 states and since the beginning of the current administration, just to characterize them, to see if they're increased, stratified and by states and a number of other things. And then so as a lot of those proposals really around personal liberty. It's really around my individual choice. And so what those messages look like that target value in that value system are messages that I think are being framed much differently than exactly your question, as opposed to public health and herd immunity. My neighbor can't get vaccinated because she is an autoimmune disease. So and so can't get vaccinated. And those are the messages that are tried and true that we work for a really long time, that it not only protects you as an individual, but your community as well. And so now you see the resistance or the root factors of that, kind of tapping into people's value system, which in part is related era-wise to some politicization. And so then the messages are tailored and shifted to those reasons around those personal liberties, individual choice, a lot of nuance there. And so yeah, so that was maybe not my best example, but a real life example of
Yeah.
how they went from 12 exemptions to zero, because the
Wow.
nurse said absolutely every family who refused to vaccinate, when they found out that they were going to lose out on whatever they were going to spend 3 weeks doing with the kids in school, that they had to, every single family then vaccinated. This was elementary entry
Hmm.
as opposed to middle school requirement, as
Yeah.
opposed to the adolescent.
They need more. Yeah, that makes sense. We are out of time. Thank you so
Okay.
much. Really appreciate your sharing your time and expertise and slides and information. I ask everyone to please fill out the evaluation form when you exit, and we'll see you at the next webinar.
Thanks so much. Sorry for the summer brain and
It
have a
was
good
great.
rest of summer. Cheers.
Thank you. Thank you. Bye bye.